I just want to make sure you can hear me in the back. Okay, awesome, great. Well, thank you guys so much for for hosting me for this mini sabbatical. It's been just a wonderful experience. I've just had the greatest time, and more than just the greatest time, I've learned so much from all of you, and I want to congratulate you on such an amazing environment here. You know, and that comes from leadership. So Bob, Teo, I know Claude can't be here today, but you guys have created an atmosphere that's just really unparalleled. It's amazing. So congrats. And I've gotten to benefit from it. I had my own cross core where folks gave me amazing advice, and I'm taking that advice and going ahead with it. So thank you so much for having me here. I'm going to talk today about smoking. Before I do, I should make a disclosure. So I serve on a data and safety monitoring board for a drug unrelated to HIV and unrelated to smoking. It's a Pfizer drug. Pfizer makes varenicline, which is a smoking cessation tool. So that's sort of a declaration of potential conflict of interest. Okay, so smoking, the greatest threat to people with HIV. I'm going to give a little bit of the background on the epidemiology of smoking in the setting of HIV. I'll move on to causes of higher rates of smoking and HIV, and hopefully bring some new concepts into the discussion. I'll talk about interventions for quitting, including talking about a trial that we did of the drug varenicline, and then a behavioral intervention that I've been working on in Botswana called the Totloetso study. And then I'll make some conclusions and talk about future directions. So outside of the realm of HIV, smoking is a major problem in our country and in the world. It's the #1 cause of premature death. $300 billion in medical costs and lost productivity, and all of the complications that you know very well. So lung cancer is the one I think people think of the most and are the most worried about. COPD is a very difficult way to live your life. But look at the most common. So this is 29% and 21% of the 480,000 U.S. deaths a year. So think about what that is in the rest of the world is an enormous number. Heart disease is actually #1. So this is, you can imagine you're inhaling toxins, but these toxins also have vascular toxicity. And I'll talk a little bit more about this later. It causes other cancers, stroke, other diagnoses. So if you weren't convinced yet, you're convinced now. Smoking's really, really bad for you. And if you're a smoker, the most important thing you can do for your health is to stop smoking. If you quit by the age of 34, assuming you've started at the typical age of onset, your survival curve is the same as never smoking. But the risk accrues over years if you don't quit. Yet if you quit even by age 65, so there's hope for you yet, you will still benefit from quitting. So this curve shows that if you're a current smoker, your life expectancy is substantially shortened. If you're a never smoker, clearly the curves are going to diverge because you're going to live longer if you're a never smoker. But even if you quit by 65, okay, you don't get the same curve as never smoked, but you certainly don't get the same curve as a current smoker. So there is always a benefit to quitting, and so hope should spring eternal for people who smoke. You have the potential to quit, and if you do, you will reap benefits. Now moving on very quickly to HIV, because this is a major problem for us in the HIV world. And this is a comparison of people who are HIV positive versus HIV negative. This is the proportion of people who currently smoke. And you don't need a statistician to tell you that this is 2 to 3 times higher in people with HIV. Something major is going on with our HIV population where people smoke. And figuring out why and how to intervene on it is going to be critical. So this is clearly a major, major issue in our HIV population. Robert? Yes, sir.
Do we know if that is pre-infection or post-infection?
So that's a great point. Can everybody hear? Do I have to repeat questions?
Yeah, you can repeat.
Okay. So Teo asked if people are acquiring HIV and then start smoking, or if people are smoking and then acquire HIV. I think the timing is probably they start smoking first, but they're probably somewhat concurrent. Very, very difficult to tease those two apart because you'd have to be capturing people's behavior probably in adolescent periods when you're trying to intervene on both HIV and smoking. So it'll be very challenging to figure out. We don't know the answer. I am going to try to do some pre-post studies that I'll talk about later, but it won't be able to answer that question. Please.
Is that regardless of viral load?
Is this regardless of viral load? So most, I don't know the direct answer, but most people with HIV that are in care in the global north have undetectable viral loads. And so I can tell you from our clinical experience, the vast majority of people who come back have an undetectable viral load, and yet they're smoking at rates that are 40%. So it could be worse with a high viral load, and I'm going to go into some of the reasons why HIV viral load may make smoking worse from biological reasons. And you could also imagine that people who smoke may be more distressed and may have more difficulty taking their medications. So it would be very difficult to tease out a cause and effect, but I'm going to work on that, and I'm going to talk about that a little bit later. Okay, so these are data from the US on the distribution of sort of the different epidemiological determinants of smoking. So if you look by age, there is not really much going on with the smoking rates in the 40s. If you're young, if you're older, there's just not very much of an age gradient. This is a problem across the ages. This is also a problem between the sexes. So for people who were around in the 70s, and remember the Virginia Slims commercials that tried to get women to smoke, they succeeded. You've come a long way, baby, was the mantra back then, so that women could be equal to men, and they've gotten there, unfortunately. So not a lot of gender difference, transgender, wider confidence intervals, but looks like perhaps lower rates of smoking in transgender folks. Socioeconomic status and employment. These follow gradients that you might expect, with people who've attained lower education levels more likely to smoke. 50% of people with HIV who have less than high school education are smoking.
Are these for smokers or people who've ever smoked a cigarette?
Current smoking. No, for people who ever smoked a cigarette, I think these would be very close to 100%. So these are current smokers, which is, yeah, you're highlighting the scary point that this is a prevalent problem that we've got to deal with. Not they had this history and we've got to screen them for lung cancer or worry about are they going to have complications later. This is now. People below the poverty level, so lower socioeconomic status. The price of cigarettes has been raised in order to discourage smoking, and that works to a degree. It's not working to the degree to get people below the poverty level, much below 50% in terms of smoking. So major challenges for people who have lower education and more poverty, and you can imagine that these people are highly correlated with each other. Now I'm preaching to the choir about mental health and smoking. People who binge drink alcohol have exceedingly high rates of smoking. This may be because the substance use behaviors go together, but there may also be a biological effect that I'll also get into a little bit later on how alcohol impacts liver enzymes, which may impact your likelihood of smoking. So well-recognized risk factor for smoking. And if you think about it, binge alcohol use is a risk factor for HIV. So if you binge drink and smoke, you're probably also more likely to acquire HIV because of the binge drinking, and so that probably bumps this number up to a degree. So clearly these things are all interrelated. And then depression, which is obviously also linked to alcohol use. Major depression, exceedingly high rates of smoking. So these comorbidities that you all know very well and study in great depth are all pretty strongly related to whether someone is going to smoke. So let's take it out of the US context just for a second, because you might say, okay, in the global north, there are the drivers of the HIV epidemic are, or at least historically, have been somewhat different than the ones in the global south. And in many ways, HIV is sort of more normative. People are less marginalized in the global south in many ways who acquire HIV. And so you might think that if it were solely the social milieu, the risk factors for HIV that also co-occur with smoking would ramp up our numbers. You'd go someplace like the Global South, and HIV would go away as a risk factor for smoking, and it would simply be you'd have smoking rates that are similar to the general population. So maybe there is something about HIV driving all of this. So we looked in Botswana to see what the smoking rates were, and we were somewhat shocked. So this is 375 HIV-positive individuals on antiretroviral therapy in Botswana, which is where I do the bulk of my non-US based work. We had a breakdown of 63% female, 26% male, and various age categories. Current smoking in men was 50%. That's not a typical number for Botswana. So you could argue all of the social drivers of smoking and all the sociocultural things that may relate to smoking. The smoking rate in Botswana is substantially lower than that. And as reflected in women, was only 6.3%. It's still quite stigmatized for women to smoke and has not been taken up. Unfortunately, they missed those 1970s Virginia Slims ads. But if the smoking rate in men is 50%, it suggests that there may be something about HIV itself, not the milieu, but literally the viral infection that may be driving this. And that's some of what I want to go into more in detail. Well, maybe it's just people with HIV don't want to quit. That's not true. If you look in red, people without HIV, in blue, people with HIV infection, the desire to quit is about the same. People who smoke don't want to smoke, for the most part. They want the benefits of the smoking, and we'll probably get into things like vaping and other nicotine delivery systems, but people want to quit smoking. A lot of people have attempted to quit smoking, and the rates are very similar between people with HIV and without HIV. And in fact, the people with HIV are more likely to have used pharmacotherapy to quit smoking. They're people that have a medical illness, and so they're in care. And so if they have a good provider, the provider will raise the potential to use pharmacotherapy to help them quit. They've had a higher rate of accessing pharmacotherapy, which certainly augments the ability to quit, and yet the success with things like nicotine replacement therapy are pretty abysmal. I mean, 10% quitting if you use the patch is really, really low. So something's going on here that we need to get into, and I'm going to try to unpack some of that now. This is an ad from one of our clinical trials, which is that smokers with HIV lose more years of life to smoking than from HIV. So of course this assumes you're in care, you're on antiretrovirals, you have an undetectable viral load, which is the vast majority of our patients who are in care. There's a lot of people that can't engage in care, aren't in care, and they have challenges, and we work on those challenges, but I'm not talking about those folks now. I'm talking about the folks that we see on a routine basis. They're losing more years of life to smoking than HIV. Part of this is the great news of antiretroviral therapy being so wonderfully effective at keeping people alive. And then the other part is that smoking is so devastating and is unfortunately so common and so hard to get rid of. So these are data that just came out in Lancet HIV in January from a large cohort, and it's the relation between smoking and the traditional risk factors for complications in people with HIV, meaning the traditional risk factors for MI, the traditional risk factors for cancer. And of course, smoking is one of the major players. So here, this is the population attributable fraction. This is the amount you can blame any one risk factor for a complication that occurs. So the higher this is, the more that factor is impacting. And here are the different categories of factors that cause MI. So smoking causes MI, high cholesterol causes MI, hypertension causes MI, diabetes causes MI. And then you can ignore the blue, just focus on this pinkish bar. These are people who have an MI, and smoking MIs can attribute 37% of their cause to being a smoker. Now, certainly, elevated cholesterol is something we have to deal with. It's a big risk factor, and hypertension is. But these are the kinds of things where we have a lot of our patients on antihypertensives and cholesterol-lowering drugs. We need to deal with this factor somewhat better. What about cancer? Again, the same graph from the same paper in Lancet HIV. the population attributable fraction causing cancer, and smoking is the big elephant in the room. 24% of cancers are attributable to smoking. And you know, in the bad old days, we feared Kaposi sarcoma in people with very low CD4 counts. Low CD4 counts are explaining very little of the cancer risk. Detectable viremia is explaining very little of the risk. Clinical AIDS say, you know, these are all sort of getting at the idea of immunosuppression. So immunosuppression isn't what's causing cancer. What's causing cancer is smoking. And to a degree, hepatitis B, which causes liver cancer. Okay, so hopefully you're very scared now that we have a major problem that we need to do something about. Now let's talk about what the causes might be that we need to do something about. Okay. I want to start with talking about mood and cognition because there's a really interesting interplay between the mood and cognitive dysfunction that you get from stopping smoking and the mood and cognitive dysfunction that you get from HIV infection of the brain. And so when you withdraw from nicotine, when you stop and people quit smoking, they you know, it's well known that they get mood disturbance. We know that other mood disturbances like depression and anxiety increase the risk of smoking and decrease your motivation to quit because for people who haven't smoked, and my team in Botswana never smoked, and I never smoked, and we had to read about this, that there's a benefit to smoking. People enjoy smoking for a reason, and it's for many of them it's an anxiolytic, and it helps with their mood, and so they see a benefit to it. And so quitting has a downside for them. It's a short-term downside, but you have to keep in mind that there is some downside to quitting. It's one of the reasons why people don't do it. Certainly medically, it's all upside, but personally there are downsides. Okay. The interesting thing is that the domains of cognitive function that are impaired by abstinence from nicotine are very similar to the ones from HIV-associated neurocognitive deficits. And these withdrawal-related mood disturbance and cognitive impairment predict relapse. And so if you're someone who has these impairments from HIV, you may be more likely to experience them worse, and then relapse more rapidly. So here are the domains that we're talking about that are similar. So if you quit smoking, you have difficulty with sustained attention, with your working memory, with processing speed, with your inhibitory control. And you can take someone in a lab. We have taken people into the lab. We have them quit smoking and then do these tests, and they perform less well. Now, if you have people with HIV, even if they have undetectable viral loads, if you do neurocognitive testing, you will find subtle deficits. Some not so subtle deficits, but in a large proportion of people, you will find deficits. And these deficits can be in attention, memory, processing speed, verbal fluency, executive function. So there's a huge overlap here between these syndromes, and they may interact with each other. So now I want to move on. Please, Susan.
Is there a protracted abstinence syndrome with quitting smoking beyond withdrawal proper, like in cocaine? You get the withdrawal symptoms like 18 months out. There's all sorts of bad feelings because of the abstinence.
Interesting question. So the question is there a prolonged abstinence syndrome such that a year and a half after being abstinent from the substance, here it's nicotine, Susan raised the question of cocaine, can you still have the I think you're talking about craving in a way.
Even not quite yourself, your energy level, your mood.
Does that persist? I don't think that persists to the same degree with smoking. Certainly you can have craving or anxiety or environment or other circumstances can make you relapse, but I don't know that I don't know how long the neurocognitive deficits last, but I don't think it's quite as long as for something as cocaine. But I'm not an authority on that, so I'll have to look into it in more detail. Interesting point. Okay. So I want to move on to a biological phenomenon that you might not be familiar with that I think is going to emerge as a very, very important point in in this story, and that is the nicotine metabolism ratio. And that has to do with nicotine clearance. So I'm moving away from some of the behavioral effects and the brain effects, and I'm moving into the biology of nicotine metabolism, because I think it turns out that it's likely going to be central to this whole story. So let me give you a little bit of background on nicotine and nicotine metabolism. So nicotine is metabolized in the liver by cytochrome P450 CYP2A6. So you may have heard me talk about CYP2B6, which is the enzyme that metabolizes efavirenz. This is CYP2A6. It's a different one of the liver enzymes, and it metabolizes about 70 to 80% of the nicotine to cotinine. The cotinine is then 100% metabolized by CYP2A6 to 3-hydroxycotinine. It turns out that if you take the ratio at any point in time in a smoker, if you take the ratio of 3-hydroxycotinine to cotinine in blood, in urine, in other body fluids, it's a very stable number, and it reflects how your CYP2A6 is functioning. There's variability in CYP2A6. Some people are slow metabolizers, some people are rapid metabolizers. It's genetically determined. It's in part determined by environment and some other factors that I'll go into, but it is predominantly genetically determined. And so there's been this kind of Mendelian experiment of some people are slow metabolizers, some people are rapid metabolizers, and you can see that if you have a normal metabolizer group, their 3-hydroxycotinine to cotinine is on average at this level. It drops down if you're an intermediate metabolizer, and then it drops down to the lowest if you're a slow metabolizer. There is some overlap between these groups, but this is quite a reliable measure of your CYP2A6 activity. I'm going to tell you why you should care in a few minutes. So hang on to that. You will care why someone has faster or slower clearance. The reason we use this instead of just looking at the gene is because we haven't identified all of the CYP2A6 alleles. So instead of genotyping and looking for every potential mutation, you can just measure this and say, I don't know what mutation you have. I don't know what your genotype looks like. I just know that this is how fast you metabolize nicotine. And it's a really stable measure. If you measure it over time within the individual, it is essentially a biological trait with some variability due to the environment. And it makes a lot of sense to clinicians if you tell them, okay, give me this point measure, and it'll tell you whether someone is a fast or slow nicotine metabolizer. Okay. Other influences: women tend to be faster metabolizers of nicotine than men. People of African origin are slower metabolizers of nicotine. So here are men. This is the proportion of the subgroup within the sample, and the purple is the fourth quartile, the fastest metabolizers. And so men are less likely to be in the fastest metabolizer group than women. Caucasians are more likely to be in the faster metabolizer group than African Americans. I don't have the data on Africans here, and the variability within Africa tends to be bigger than the variability between people of African origin and people of other origins. But I can tell you that in our sample in Botswana, the numbers are looking like that. Okay. Why do you care? This is why you care about nicotine metabolism. If you look at the rate of quitting in a trial of a nicotine patch or a spray, the likelihood that you will quit decreases as you go from the first to the second to the third to the fourth quartile, and if you go from the earlier period to the later period, right? You can have early success with quitting and then later go back to smoking. And so we know that over time, people are less likely to be quit. That's sort of a smoking phrase, be quit. It sounds like be best, but are you quit is something that people use in the smoking world. So clearly nicotine metabolism ratio is important for your likelihood of quitting. And as you go to the higher quartiles, your faster clearance, you're less likely to quit. And if you look at this lower study, the light blue is placebo, and the purple is bupropion, one of the smoking cessation aids. Bupropion is not affected by your nicotine metabolism ratio because bupropion isn't nicotine. It's not related to whether you don't clear bupropion in the same way as you clear nicotine. And so your likelihood of having success with bupropion was just the same, not influenced by the nicotine metabolism ratio. But if you were on placebo, you were much less likely to quit. It's harder for people who rapidly metabolize nicotine to quit. There are a couple of other environmental factors I'll just touch on briefly. Body mass index is negatively correlated. Alcohol use is positively correlated with NMR. So if you're a binge drinker, you're going to upregulate your nicotine metabolism. You might think of, well, alcohol damages your liver, and so your liver won't be able to clear the nicotine. That's a late effect. Earlier effects are it stimulates the liver and it increases your liver enzymes, including nicotine metabolism enzymes. Smoking mentholated cigarettes reduces your NMR, and increased cigarettes per day increases NMR. This relationship can be reversed. Of course, it may be that you just smoke more cigarettes because you have a faster NMR. So don't necessarily take cause and effect here. Is it important in HIV? Of course it's important in HIV, otherwise I wouldn't be spending so much time talking about it. And here's the evidence of this, and this is a paper that we published in JADES. I think it may be available online. I don't know if it's in the print issue yet. But here, again, this is end of therapy quit rate on the y-axis, and these are slow metabolizers and these are fast metabolizers. The gray is you got placebo, and the blue is you got varenicline. This is in a randomized trial of varenicline, and I'm going to give you the more formal results when I talk about interventions in a few minutes. But you can see that if you are a fast metabolizer, varenicline works much, much better than placebo. If you're a slow metabolizer, varenicline doesn't actually work that much better than placebo. And so there's something going on with varenicline in the setting of being a fast metabolizer that may make it a potentially important drug. But if you used open label nicotine patch, if you're a fast metabolizer, substantially lower rate of success at this is just at 4 weeks. So fast nicotine metabolizers don't benefit from the patch anywhere near slow metabolizers. And if you follow this over time, these rates really, really drop. Question?
I'm just curious. I mean, it seems like it does actually. The effect size is actually the same between placebo and varenicline in the two groups.
Mm-hmm.
It's just that the baseline risk or baseline success risk is lower than slow metabolizers, so that's eroding some of the statistical power in that comparison.
Yes, but if you look at the overall though, slow metabolizers don't respond as well as fast metabolizers. So if you look at fast metabolizers on varenicline, it looks like there's a difference here, and it may relate to side effects. We have some evidence that side effects in fast metabolizers, side effects of varenicline. Varenicline is a drug, and I'll go into it. It binds to the alpha-4 beta-2 subunit of the nicotine receptor, has some agonist effects, and it prevents nicotine from binding, and it may decrease some of your withdrawal symptoms, and you probably have fewer side effects from the varenicline if you're a fast metabolizer. We don't fully understand that, but we're working on that. So if you're a fast metabolizer, nicotine patch, even if 4 weeks doesn't work particularly well, later you're going to see it works even less well. Okay. What about the nicotine metabolism ratio in HIV? Is it distributed the same as in the general population? And the answer is no. So here are people, a sample that we have of people without HIV in the clear bars and people with HIV in the dark bars. And you can clearly see that there are a lot more people without HIV in the slower metabolizer quartiles and a lot more people with HIV in the fast metabolizer quartiles. So this really struck a nerve with us. We said something's going on in this HIV positive population that's making them have faster nicotine metabolism ratio. I mean, you could postulate, is it all driven by these people are much more likely to be binge drinkers or other factors? And you can hypothesize those kinds of things, but we think that it might be HIV itself, and that's what we want to investigate. I mentioned efavirenz before, and efavirenz is a drug that has major effects on liver enzymes. So efavirenz is metabolized by CYP2B6, but there's some evidence that efavirenz, and it induces its own metabolism. That's been known for at least 20 years. But one of the things that efavirenz might do is it might upregulate CYP2A6 as well. And if it does that, efavirenz may be one of the drivers for a faster nicotine metabolism ratio, which makes you more likely to be addicted and have trouble getting off. So if you look at CD4 count between people who are fast metabolizers and slow metabolizers, there's nothing going on. If you look at undetectable viral load, you're more likely to be a fast metabolizer if you have an undetectable viral load. And so this might go counter to what we were talking about before, where HIV might upregulate your nicotine metabolism. But I think what's driving this is that the drug that's causing your undetectable viral load, which is helpful, happens to be efavirenz, which may be harmful by increasing your nicotine metabolism ratio. So you have a complex story of nicotine metabolism ratio may be driven up by HIV, may be driven down by antiretroviral therapy, but if you pick the antiretroviral therapy that upregulates your CYP2A6, it might be driven up again. Question?
I have two questions. The first is, can you just talk about how NMR is actually measured? Like, do you just draw blood? Is it a cheap test to do?
Yep.
And then the second question is, is this like cross-sectional associations, or have you looked at the longitudinal, trying to kind of tease out what comes first?
So let me answer the first question, and then I'm going to ask you a little bit more about the second question. So the first question was, well, let me ask you to go into a little bit more detail about the second question. So you asked about longitudinally looking at NMR.
I'm just curious, like you're saying that faster NMR is associated with undetectable viral load. So if you had a longitudinal study, you could see, as people, as their viral load changes over time, and say they incorporate efavirenz into their regimen, like, do you see this change? Because you also mentioned that NMR is something that tends to be stable over time. So
Great. So the question was, if you look longitudinally over time, what's causing this change? NMR? Is it going up with HIV? Is it going down with suppression? Is it going back up with use of efavirenz? Teasing that out. So that's the grant that I'm writing right now, and I'll talk about that in future directions. So that's exactly the direction I want to go, is figure out what's driving. If this is a stable number in people who don't have these perturbations, but changing your viral load is a major shift. And going on a drug that's a CYP2A6 inducer is a major shift. So NMR, when I say it's stable over time given the fact that you are who you are, you behave in the ways that you do, and you don't have major changes going on in your health. But with HIV, all of that goes out the window, and that's exactly what I want to tease apart. The other question was, how do you measure NMR? And it's a very simple test. It's liquid chromatography. It's straightforward. There are several labs. The lab we use is at the University of Toronto, Rachel Tyndale's lab. And I think I don't want to give you a price quote because she has to give you the price quotes. But let's say it's more than $25 and less than $100 per test.
I'm curious, like, is it something that could be incorporated into clinical care, so you could target the right kind of, like, do you do the patch or do you?
Right. So could you incorporate it into clinical care? And that's a trial that Robbie Schnall is doing right now. He's randomizing people to getting their nicotine metabolism ratio fed back to them and to their provider to decide on the therapy. But in a randomized trial where people were blinded, but nicotine metabolism ratio was used to determine whether you got varenicline or a patch, nicotine metabolism ratio tailored therapy works better than if you just give people drug. So I think the answers were yes, $25 to $100, and yes. Okay, so we've got a problem. We've got some drivers of the problem. What are we doing about it? Interventions. So these are the cessation rates with nicotine replacement therapy. So I showed you 50% in fast metabolizers at 4 weeks. But if you go to end of therapy is 12 weeks typically, and then usually do follow-up for 24 weeks. 10% of people with HIV are quitting with nicotine replacement therapy, whereas you would expect somewhere closer to 30% in people without HIV. So nicotine replacement therapy does not seem to work particularly well for people with HIV. What about varenicline? Well, varenicline, I mentioned its mechanism. It also has anxiolytic properties and also has impact on working memory. So this is again from our recent clinical trial. This is change from baseline to end of therapy. Anxiety went down. Now these are people, the placebo went down too. These are people who are also getting smoking cessation counseling, which is a form of therapy. So they're all getting intervened on, but these people are getting drug and they're having a greater drop in their anxiety scores and drops in depression symptomatology score from varenicline, and improvements in their working memory from varenicline. So varenicline clearly has important central nervous system effects that lead it to be successful in stopping smoking. And these are the ones that we highlighted before as being particularly bad for people who may have some of the neurocognitive deficits related to HIV. So we did a randomized trial, and this is a very typical schema for a smoking cessation trial. You baseline everybody with how much they're smoking. Everyone gets counseling, of course, as standard of care, randomized to placebo or varenicline. 12 weeks is called EOT, or end of therapy, and then you follow them up for another 12. We randomized 70 to 80 people in each group. They had about 6 counseling sessions, and then you do an assessment at 18 weeks, an assessment at 24 weeks. And here are the results. So these are the quit rates. People who got everyone has HIV in this study. If you got varenicline, your quit rate was 28% versus placebo 12%. This is at week 12. At week 18, still better for varenicline, and week 24, falling off. Still better for varenicline, but not by a ton. The paper is back under resubmission and should be getting accepted very soon. The reviewers objected to us saying that this was statistically non-significant because they said this 5% benefit has major public health implications. So they were excited by this 5%, even though we were sort of disappointed with this drop-off. But varenicline clearly works to improve outcomes, at least early quitting. So moving on to a setting like Botswana, can you do this? And the answer is, of course, you can do it, but in this era of implementation science, you can't implement it because varenicline is about $1,000 a course. So that's 10,000 pula. So that's not going to fly. And nor is nicotine replacement therapy, and it doesn't particularly work well. So I could give you some of the data on the price in pula, but I don't think you'd be particularly excited because it doesn't tend to work well anyway. So let me move on to the behavioral intervention, the Totloetsa study. So here's our framework for the behavioral intervention. So we conceptualize the problem of smoking is that when you're abstinent, you have these withdrawal symptoms. You smoke to avoid the withdrawal symptoms of anhedonia and the depressed mood that comes with the brief abstinence. So you shift this way, you smoke, you improve your hedonic capacity, you're more satiated, and this is going to drive everything in this direction. We've got to break this cycle of the withdrawal symptoms, the anhedonia, and the depressed mood in order to get people to not be briefly abstinent, but to be permanently abstinent. So here was our conceptual framework. We borrowed this, and this is going to be a familiar story to people who heard me several years ago when the gavel was still in play in this room. I stole this idea from unabashedly from the depression world. So there are so many parallels between the treatment of depression and the etiology of depression and the etiology of the problems in HIV and a lot of the depression that we see in HIV is that you can have a myriad of things that lead to the same phenotype of being depressed. And my idea was that you needed to really personalize the intervention. And so we tapped into problem-solving therapy. But we didn't want to do the full problem-solving therapy because that requires teaching of problem-solving. It was many, many sessions. We thought it would be infeasible. So we adapted it down to managed problem-solving, where it was shared problem-solving between the interventionist and the participant, where the participant knows what their problems and issues are. The interventionist is skilled at problem-solving and then lends a hand to the participant to help them solve their problems together. And it's a shared effort. So when talking to my smoking cessation colleagues, and they talked about the idea of borrowing something from the depression literature, they borrowed behavioral activation. So their idea was that, and this is an idea that comes from Brian Hitzman at Northwestern and Robbie Schnall at Penn, is that if you use behavioral activation, which you guys I'm sure know in much better detail than I do, is that you're looking for something pleasurable in people's lives. And again, that's going to vary immensely by person, but you're looking for something pleasurable that's still in their lives and get them to do that pleasurable thing. And it turns out that if you do that, you can, that's a quite effective treatment for depression, just activating them to behave in ways that bring them pleasure. My concern was, and then it was adapted for smoking. So find things that you could incorporate in their lives that they find pleasurable that are linked to not smoking. The converse is also true. You need to find the things in their lives that they find are pleasurable that are linked to smoking. So if you like to drink coffee, and it's pleasurable, and you like to smoke with that drinking of coffee, that's a pleasurable activity that we're going to need to figure out how to avoid. Whereas if there's something like playing a sport discourages you from smoking, you don't like to smoke when you're playing a sport, or you don't see too many people going to the sidelines. Maybe golf. Golf I won't count. But other sports, you don't see too many people going to the sidelines, having a couple puffs and going back into the game. And so those are the behaviors that you want to try to encourage. So that was developed into a behavioral activation smoking cessation strategy. My concern was that in Botswana, trying to do that without that shared problem-solving strategy was going to fall flat. And so what I did was I brought problem-solving into the behavioral activation smoking cessation, and we created a hybrid behavioral activation problem-solving intervention that addresses your causes of stress and depressive symptoms. It uses the problem-solving skills of the interventionist to help you come up with a tailored plan for behavior change. The behavior change is meant to increase your substitute reinforcers. That's the phrase that we use for the pleasurable activities that substitute for smoking. It's very easy to say to somebody, well, you should just chew gum or sucking candies. Well, what if I don't like chewing gum and I don't like sucking candies? That's a bad suggestion. Why did you come up with that suggestion? So instead of you telling me what I should do, we come together and we say, well, what are the things that you find pleasurable that could substitute? And then together pick the ones that you're going to use to substitute. And then we try to decrease the complementary reinforcers. We're trying to decrease those pleasurable behaviors that also trigger smoking. Okay, and then hopefully that leads to smoking cessation. So we entitled it the Totloetso study. Totloetso means encouragement in Setswana, to adapt this behavioral activation by identifying an individual's pleasurable activities, classifying them as substitute or complementary reinforcers, increasing these, decreasing those, and do it entirely by telephone, because Botswana is a very, very rural country. It's the size of Texas with 2 million people, and yet a very robust telephone system. And so we wanted to purely deliver it by telephone, but had to give them weekly homework in order to keep them engaged and working on their issues. Okay, and so so our adaptation process was translating to Setswana and back, and iterating it until the manuals were considered absolutely equivalent. And we asked about concepts that might be culturally irrelevant in order to say, okay, maybe we should eliminate this piece or change this piece or modify it. We didn't find anything. Everybody felt that the items that were relevant here to smokers were relevant there to smokers. So we kept everything in the mix. We trained 5 individuals, none of whom had either smoking cessation or clinical research experience. None of them actually even had smoking experience. We had to explain to them when they were doing their recruitment that the people who smoked knew that smoking was bad for them. They weren't just dumb and smoked because they didn't know better. They smoked because they were addicted and it was a much deeper issue. Our enrollment focused on teamwork and non-judgmental attitude. This was actually quite challenging, and this is a great reason to do pilot studies. We've had a lot of discussion of pilot studies at the Cross course, and I've really appreciated having done this pilot recently. These were several of these were nurses, and I'm not a nurse basher. I'm a nurse supporter, but the nurses in this setting can often have very judgmental attitudes, and there was a lot of finger wagging of for the smokers. So we thought we were going to enroll by the fistful. In Botswana, there are just so many people who are in need, and there's a belief in research. It's a wonderful place to work from that perspective. I thought we were going to enroll very, very fast, and after 2 weeks, we had very few people enroll, and so we role played, and I played the role of the potential enrollee, and they played their role. And I said, well, I'm a smoker and I want to quit. And I got a lot of, smoking's bad for you, smoking's bad smoking, smoking bad, quit, bad smoking, you should quit. Nobody wanted to enroll. So when we reversed the role play, and then I played them, and somebody brought up the issue that they were struggling with something in their life, and it was really causing them to want to go out and smoke. And we switched it around to where we said, we know you want to quit. We're here to help you. We're never going to scold you. We're never going to judge you. We recognize this is really hard. Join our team. We're going to create a team. It's going to be you and us on a team together working to advance your goals. We enrolled 40 people in 3 weeks. So that was really, really gratifying. And that for the fellows, this is why you want to do pilot work. For Yvonne, I included this bullet here, that fidelity was assessed by audio tape and checklist. I got the memo, Yvonne, that this is important, and it was critically important. Interestingly, in this setting, we found that so these were all done in Setswana, and so I can't judge, but sitting in the room with them, listening to the audio tapes in Setswana, they were more critical of themselves than I would have been. And they would raise issues. They'd be like, well, she said it this way, but I think she should have said it that way. And, they told me in English what they were saying, and it was essentially equivalent. It was fine. It was just normal variability that was allowable. So they really bought into the idea that fidelity was critical, and that was really, really, really gratifying. And our goals of the pilot were feasibility, acceptability, and preliminary evidence of potential efficacy. So the study design, this was a single-arm pilot. Okay, have at it. Should we have done a randomized pilot? This was a single-arm pilot. Why did we do a single-arm pilot? And I put this in because of the last cross-core. So the quit rate is known in controls. You don't need a control group to know that the quit rate in people that you don't intervene on is 0. And so any rate that we get can be compared to 0. The expected quit rate was also known. We know that from counseling, about 10 to 20, you can get 10 to 20% of people to quit through counseling alone. So this is a number we were targeting. And we followed people only through end of treatment. We did not follow them for the full amount of time. Grants got to go in, and it was just a pilot. And so we were not looking for something definitive. It's just a pilot for feasibility, acceptability, and merit, maybe preliminary evidence of efficacy. We targeted a sample size of 40 because we thought that would really get our feet wet, and it felt like it would show that we can enroll, it would show that we can deliver it, it would put somewhat of a burden on the interventionists to have a few people juggled at different stages of the intervention at different times. The outcome was a hard outcome of exhaled carbon monoxide, which is a terrific measure of, it's actually a measure of whether you live in New York. If you live in New York, your exhaled carbon monoxide is often in the 4 range. If you live in Botswana, it may be 2. Maybe if you live in rural Iowa, it would be 1. But if you're a smoker, it's going to be 8 or greater. And this is just simply done with a handheld device that we were able to bring to Botswana. We used this as a hard outcome so that we didn't rely on self-reports. And then we did some exit interviews. How am I doing for time, Teo? Okay. And here are the results. So we enrolled, as you would have expected from the preliminary data that I showed you on the smoking rates in Botswana, we enrolled mostly men. So 95% were men, and their median PHQ-8 is a measure of depressive symptomatology, and we incorporated this in, we translated it into Setswana, back translated it. We feel like we have a pretty good measure. About 2 of the 8 items were endorsed on average. Some people had more distress of 4. We did have 1 or 2 people that say they've chronically been suicidal for quite a while. So there was some distress, but this wasn't a frankly depressed, floridly depressed population. They had some distress. 20 people completed the full study. This is not surprising. When people can't quit smoking, they're not going to keep coming back and hear about how they shouldn't be ruminating or how to deal with rumination and how to deal with all these issues. If it's not working for them or their side effects are too severe, they often just don't come back. And as I told you, only 10 or 20% are expected to succeed. So this number is not at all surprising. But the quit rate, which is quite surprising, and it's depicted here in this figure. This is your exhaled carbon monoxide in parts per million. This is 8 or less, so these are the people who quit. These are the people who didn't quit. This is only on the 20 who remained at the end. We'll just impute the fact that the other 20 are still smoking, which means of the 15 of these 20 had quit by the end of therapy. So overall, 15 of the 40 in the intention to treat sense of we'll just impute the other 20 as having failed, gave us a point estimate of 37.5% quitting. Don't hang your hat on this. We need to do the full-on trial. That grant is pending, but at least this gives us a lot of hope that we're onto something that's appealing here. We did exit interviews. Of course, everyone who finished the study said, oh, of course, I'm in favor of doing behavioral activation, smoking cessation. If they hadn't said that, I'd be shocked. But at least they endorsed it, and they said they would refer others. But I have some quotes here that I picked out to try to give you a sense of why did this work, or at least what people thought about it. So here are some of the exit interview quotes. Look at me now. I'm healthy. I don't even complain about any pain or breathing difficulties I used to have. By the way, I did not, you have to trust me, I didn't make any of these up. And when my staff gave me these, I'm like, okay, you're not allowed to make up data. And they're like, no, Prof, we're just translating what the patient said. So I'm promising you this is what people said. So look at me, I'm healthy, I don't have breathing difficulties. This program could help a lot of Botswana. This is the plural for a citizen of Botswana. It could really help a lot of Botswana. If it has worked for me, someone I thought would never survive without a cigarette, then surely it can work for anyone. Okay, maybe that person's a little over the top, but that's how they felt. I'm back and actively involved in my local football team, meaning soccer. So this may have been the person's substitute reinforcer. They want to smoke, instead they're going to go play football. They go play football, they're discouraged from smoking, they don't want to smoke. It doesn't make you feel good when you're running up and down a field. And the fields in Botswana are very dusty, so you really don't want to be smoking. Before this program, I only had one activity, which was smoking. This program has helped me a lot in dealing with my home stress issues. Not only have I learned techniques to deal with stress, but also the power of choosing good friends. And I give lectures to the young ones in my neighborhood with the papers that I use from this program that help me stay quit. So this is the homework that we handed out. Not only have I quit smoking, but I have an improved mood, which was also one of our goals. And one person did say, reduce the paperwork. Homework is too much. We don't want to do so much paperwork. And we did reduce it by not making it paper and pencil. We made it telephone administered. So we would call them and say, how are you doing with the homework? What's going on? How many cigarettes did you smoke in the last day or the day before? Ask them what their triggers were for that individual cigarette to try to highlight where the complementary reinforcers might be getting in the way and where they might need to implement their substitute reinforcers. Okay. So our conclusions is that the behavioral activation problem solving for smoking cessation is acceptable and feasible. There's preliminary emphasis on preliminary evidence of efficacy that's greater than expected. The limitations, it's a pilot study. There were only 40 people. We handpicked the staff. We personally trained and monitored them. The question of whether there should have been a control arm is something I will allow you to discuss at the next cross-core that I will not attend. Okay. Conclusions and future directions. So, smoking HIV, it's very common. It's hard to quit, and it's a threat to gains in health from antiretroviral therapy. I suspect you knew all those before you came in here. What I hope you got more out of was the multifactorial etiology of these high rates, that there are social issues that I'm sure many of you attend to, but there are these biological issues that I think are incredibly fascinating, and where some of the questions you raised are the things that we want to delve into, and I'll talk about what those studies are going to be. Interventions are obviously feasible in a variety of settings, including in Botswana, and we need to test and roll out strategies, which has been the theme of this decade, I think. So future directions. Clinical trials. 2 are pending, are under review. This clinical trial is to use NMR to select treatment. You get varenicline if you're fast, nicotine replacement if you're slow, versus just everybody being offered varenicline. We're doing that in a 2x2 factorial design with maps. So the Bob referenced maps when he was introducing me. We're using managed problem solving, and instead of for antiretroviral therapy, we're actually going to use it for varenicline because there's a very strong relation between adherence to varenicline and your likelihood of quitting. So we need to boost the quit rates. We want to boost your use of varenicline, and we're doing this as a 2x2 factorial design. Well, at least we proposed it that way. The behavioral activation problem solving is proposed as an RCT, and that'll be reviewed next month. That's compared to a standard smoking cessation counseling in Botswana. This is without drug, without nicotine patch, without varenicline, just straightforward smoking cessation behavioral interventions. And then I think future directions that we haven't yet proposed are to switch off CYP2A6 inducers. So if you're on a drug that's a CYP2A6 inducer, do a switch study, or add CYP2A6 inhibitors, which I'm hoping to start doing some pilot data on. Give people who smoke CYP2A6 inhibitors to decrease their nicotine metabolism ratio. You might ask me what one example would be, and I would tell you that the drug isoniazid, which is ubiquitous, well, should be ubiquitous in sub-Saharan Africa for people with HIV because of the prevalence of TB and the evidence that it decreases TB rates. It's not being used as widely as it should, is a CYP2A6 inhibitor, and if that can help you get off of nicotine, it might be worthwhile giving people isoniazid even if they don't need it for tuberculosis. And then the observational studies that were already raised, looking at the effect of HIV infection on nicotine metabolism ratio and the effect of antiretroviral therapy on nicotine metabolism ratio. Those are grants that I'm actually writing right now. So, acknowledgements. A ton of people involved in this. Robbie and Becky are world leaders in smoking and HIV, and were kind enough to allow me to join their group and also to share most of their slides with me. Dilit Seema is a graduate of my Fogarty-funded D43 program and is leading the charge for smoking cessation in Botswana. Precious is a trainee who trained on the Totloetso study. Jess Fishman's a behavioral scientist. Warren Bilker's a biostat. My staff in Botswana were fabulous, and Jessica Weisbrot trained them all in how to do smoking cessation, and Joe did it in person, and Joe did it by Skype. The informatics folks in Botswana and my stakeholders in Botswana, it is remarkable how much you can get done in Botswana because you have stakeholders who have a degree of trust with us, have a desire to advance, and they believe that science is going to advance health in Botswana, and I'm right there, shoulder to shoulder, partnering with them. Appreciate the CFAR for supporting me, Fogarty and NIMH for my support, and then here are many of the folks on my team. These folks conducted the smoking cessation trial, and then here's Robbie and Becky, and I'll close and be happy to take questions. Thanks.
That is really cool. We got a crash course on smoking and HIV, and you presented it in a way that I feel like I can articulate some of this stuff afterwards. It's really helpful.
Thanks.
I'm wondering about the loss to follow-up in the pilot study, those 50% who were lost. If you have any sense of the correlates of those folks, or if any of them were willing to participate in exit interviews, that sort of stuff. Yeah,
so the question was why are we losing people, and can we, in the pilot, we lost half of the people. What's going on with them? Can we get some more data on them? So the first thing to tell you about is that we spend a lot of time interacting with these participants just to say, you've got a session coming up, remember I'm calling you tomorrow, etc. And after a certain period of time, they started ghosting us. And so we couldn't, they didn't want to hear from us anymore. They didn't want to participate. I wonder, this is all speculative, I wonder if they were having bad feelings about the fact that they quote unquote failed. They felt like failures. We were the ones who made them feel like failures because we tried to help them succeed on this in quitting, and yet they weren't able to do it. And we tried to be as non-judgmental and as welcoming back, and we really want to talk to you, and it was really, really hard for our staff to get at them. Follow on. Go ahead.
Well, that makes me think about the abstinence violation effect, wherein people who relapse end up avoiding contact because of their relapse.
Mhm.
One component of it.
Yes.
And I wonder if that might be a part of your psychoeducation earlier on when people are learning about the intervention.
Yes.
So that they're prepared for that experience, if that wasn't already in.
Yes. So the question.
Yeah, half of you are likely to relapse or to want to avoid us or want to ghost us.
Yes. So the follow-on comment suggestion was, if maybe we should upfront address the idea that you may relapse, and if you do, we're still there for you, we'll work together, et cetera, to try to prepare them to try to decrease these negative feelings and these negative feelings that we might induce. That's really central to smoking cessation principles. It's already built in because this is just such a common phenomenon. We say right up front, if you have a slip, it's just a slip. You can get back at it, and we'll work with you on it. And it's really common. The average smoker the average quitter. So quitter here sounds like a bad word. Quitter is actually a good word in this world. The average quitter fails 7 times. Those are the people who have success. So the old joke is quitting smoking is really easy. I've done it 40 or 50 times. So I think you're right. You have to pay deep attention to it, and yet people still are very stigmatized about not being able to get over it. We did have 5 people who were still smoking who came in. So were they coming in because of the financial incentive of participating in the study? Perhaps. I can't give you specific characteristics of the folks. We didn't gather that much data about them, but yeah, it's vexing. This smoking thing is really hard in that way.
I have 2 questions. So great presentation. Are the people who have who metabolize nicotine faster, do they smoke more cigarettes per day?
So the question was about smoking. So I'm going to introduce you to a new term that's new to me, which is called smoking topography. So when you just count how many packs do you smoke, that doesn't count how far down the cigarette. It doesn't count whether you relight, which does some really yucky things to, you stop you tamp it out, but then you keep it and what's that called?
It's called clipping.
Clipping. All right. Now I'm learning new terms. And then the depth of the actual inhale and then how quickly you smoke the next one. All of those relate to nicotine metabolism ratio. So one of the things I'm concerned about is if you're a faster nicotine metabolizer and your depth of smoking is greater, and then you're getting rid of the nicotine, but you're getting all of those toxins. Nicotine has some anti-inflammatory properties. You may be getting even more toxins, and it may be even more toxic. And that's why I'm looking into the idea of nicotine metabolism ratio and myocardial infarction.
My second question is, has there been any study, or do you know of any research looking at how quick one metabolizes nicotine and their rates of success with purely behavioral interventions for smoking cessation?
So yes, so if you saw the placebo arm in one of the earlier slides, as you went from lower to higher quartiles of rapidity of nicotine metabolism, your likelihood of responding to placebo, which is basically counseling, decreased. And so it's probably because of this relapse, your cravings and your urge to relapse, which varenicline does help to break. So you have these really strong cravings that are worse than other people's cravings. You have worse side effects, worse anhedonia. Varenicline helps that even more. And so I'm arguing now for my clinic patients is I want to go straight to varenicline. I don't even want to bother with nicotine patch. It's just that it's $1,000, and so some people might balk at it, but smoking has major consequences down the line. So I'd rather go straight to varenicline.
So I have a little recommendation for you.
Sure,
if I may.
please.
And a question. So thank you for a recording session. Shout out. So counselors tend to, when they review their sessions, always focus on what they did wrong. And I make it a point that as they go around the room or in the group, they can only say positive things about what went right. which is a much more supportive thing, and also it models for them how I want them to be with participants.
That's beautiful.
And focusing on the successes instead of what went wrong.
That's beautiful. So the comment was make sure that the folks, when they're reviewing their sessions, are emphasize the positive, not don't focus too much on the negative, on what they did wrong. Focus on what they did right. I tend to be the cheerleader in the room because a lot of the folks are sort of saying, "Oh, we should." I'm like, you guys are doing great. I mean, they did amazingly well with this great success rate. So that's a terrific suggestion. I'll try to make it my feedback more concrete than just you guys are great.
Cool. Then the other thing, the question that I had was around how you did these interventions over the phone. So as part of research studies, I've done both of those separately.
Mm-hmm.
And I know that they are very form heavy, and which is part of the reason why I want to go a little ambivalent about them. But there's components, especially of VA, which are very useful to do in person, right? As you're trying to help people see their daily schedule.
Mm-hmm.
When are we replacing something when?
Because there are visuals.
Visual
Yes.
facilitation, right?
Yep.
So I'm wondering how you manage some of those things over the phone and
Yes. So the question was, how do you deal over the phone with components of behavioral activation that really would be better in person? And so the first thing to emphasize is we recognize that we're compromising by doing it over the phone in many ways. We did it for logistical reasons and practical reasons, and when you do a pilot in part because you want to learn what's not working so that when you go to do the full-on study, one of the things that we learned wasn't working is that a lot of these men worked and they didn't want to come in during the day. And my staff were employed during the day. So literally halfway through the study, I said to the staff, okay, you want to work half a day? You work 5 p.m. to 10 p.m. Whatever half a day was, 5 p.m. to 9 p.m., you'll get paid for a full day. And so my staff would then divvy up their days so that we had evening hours. That was completely novel in Botswana. They'd never heard of that. We made that change. And then we heard that they want all sessions to be by phone. We started out by doing the first one as rapport building in person with the interventionist. So the way we did it all by phone was we had the enrollment, the intake interview, just to sign the consent form, hand them all of the forms and say, we're going to be going through these with you. But we couldn't visualize with them. We would just have to talk to them about their days. So it was literally just a compromise in order to get it done. And it seems like we didn't compromise so much that it didn't have the effect.
No, I don't fault you on doing it over the phone. I think that we need to be taking treatment to where people are at
Mm-hmm.
and not making it extra impediment. I was just kind of curious as to how you manage that part of it.
Yeah, we gave them the handouts beforehand, and then they would have to sort of envision how it would get incorporated. But I'm very much about where are you going to fit this into your day. Pleasant Event schedule was easy to adapt. There were a few things that we had to add, like do you like to go game to watch game, which you would say do you like to watch a game. There it's do you like to watch game, and then we changed baseball to football. So in general it resonated with people, which made me happy.
I have 2 questions. So you were talking about using maps for the actually, let me ask another question first. First question was about the CO2 as the objective
CO
of the objective measure of smoking cessation, and I'm wondering, is that in the past 24 hours, or what is that reflecting?
It is how long does carbon monoxide stay? So if you're quit, you haven't smoked in the last day. I think 1 cigarette will put you over 8 parts per million, and so it's reflecting current. Yeah, it's not long term like weeks, but it's days. So I think the half-life of carbon monoxide, I think eventually within several days you'll wash out. So this probably means that they haven't been smoking in the last week.
Okay, and so someone couldn't probably do that unless the intervention actually worked.
Right, because if you've quit for a week, just to come in to blow into my meter to fool me, you're already 3/4 of the way to quitting. And these people want to quit, right? They have a major motivation to quit. Their motivation to quit is much greater than they're coming in and getting, 50 pula for the visit. And plus they get the 50 pula for the visit anyway. And, we try not to shame them if they're still smoking. So I think it's very difficult to game this. If you're craving cigarettes, you're going to smoke and you're going to blow greater than 8 parts per million. So it's considered the gold standard for, is someone quit?
My other question has to do with the varenicline intervention. I was just curious, you think about the PrEP trials or ART, there's all these ways now of trying to measure the amount of drug in someone's blood to see, is the issue that they weren't returned to the intervention, or is the issue that the actual intervention doesn't work?
Mm-hmm.
I was curious, is there any sort of objective measure? I know you're working to try to maintain adherence to varenicline, but is there a way to measure how much people?
So you really tossed me a softball, and I only have 5 minutes, and I need 50 to talk about measurement of adherence. So you can measure varenicline in plasma. You can do refill data. You can do self-reports. You can do all of those things. You can do MEMS caps. None of them is perfect. But we were doing blister packs, people returning their blister packs, and they were not empty to the degree that they should have been. So you can use all of those measures. I'm not the hugest fan of drug concentrations because they can reflect what was going on before, depending on how fast you clear the drug. So they may not actually be correlated with what you're doing right now. But all of those are useful techniques.
I have Ruben first. A really quick thought. Is there some level of adherence to varenicline, that's most effective if you take, half your doses or? Right.
So the question is, what's the threshold for enough varenicline? And I think it's probably like other drugs. I think it's probably more is more. So the more you take, the more likely it is to work. The less you take, the less likely. I don't know that there's a clear cutoff, but I don't know that enough foundational, certainly nothing like we've done in HIV, which is how I started my career doing that kind of stuff in HIV. Nothing close to that has been done in this world. It is much shorter also. Remember, they're only having to take it for a couple of months, or an extended period. They may be taking it for 6 months, but it's, it's nothing like antiretroviral therapy. So there's like a light at the end of the tunnel. We're seeing with Hep C therapy, there's not, I wanted to study adherence in Hep C therapy. There's not much to study there because people take it, they get cured, and then they're done. So I think here there's some motivational issues that people with Hep C wouldn't necessarily have, but certainly it's not this pill fatigue that you get from years of HIV.
I'm just curious on my pills. Do we know what the PIs do with the 2A6? I mean, so we think of protease inhibitors as powerful inhibitors of 3A4.
Right. Yes. So the question.
Because it seems like you could then think about sort of having that be part of how you choose a regimen.
You're singing my tune. So the question was, do we know which drugs influence CYP2A6 in particular, like the protease inhibitors or cobicistat? There are drugs that are designed to be CYP3A4 inhibitors in order to boost drug concentrations, and then basically don't pick those drugs for someone who might be a smoker, or switch them off. And that's exactly what I'd like to do. We don't know those details yet because we haven't even proven that manipulating the nicotine metabolism ratio will have a benefit. And so it's hard to manipulate somebody's HIV regimen, which is they have an undetectable viral load, they're doing great. And now you're saying, oh, well, let's experimentally change your meds to see if it helps you quit smoking. Might not fly until we get more evidence of this, but that's exactly the direction I want to go, is switch studies or inhibitors of CYP2A6 so that they slow their metabolism.
It seems like you do a pretty easy sort of cross-sectional study to just look, is there a difference in 2A6 metabolism between people on PI-based regimens versus?
I wouldn't even say PI-based regimens. I would say individual drugs. Unfortunately, you have to drill down to the absolute individual drug because you can't go by class. But that's the R1 that I'm writing right now. It's exactly the grant I'm writing.
I have several questions. I'm going to ask you later.
Okay.
Because we're out of time.
Okay.